Good to go. You can make us live. Good morning, delegates, and welcome back to Laryngology Summit Day 3. I'm sure you've had a wonderful time over the weekend, and we've got some very good feedback of Day 1 and Day 2, and we hope to sustain this momentum. So, starting Day 3, we'll be focusing more on swallowing, and we've got a panel of experts here who are going to talk about this swallowing and disorders and how we should address them. So to introduce the first session, I will request Dr. Ritika from my department to kindly just introduce the people who are going to moderate this. Can you please?
Yes. Thank you, sir. Good morning, everyone. Welcome to the third day of Laryngology Summit. So we start with session number 15. The moderators for today's session are Dr. Manish Munjal, sir, who is the consultant, Department of Otolaryngology, Sir Gangaram Hospital at New Delhi. He's got a gold medal for Best Registrar in MAMC in 2006. He has got vast teaching experience in teaching the DNB medical students for last 8 years and has set up the North India's first of its kind K-Pentax voice clinic at SIR Gangaram Hospitals, especially caring for the voice and swallowing disorders are today's main focus. He has got numerous publications over past 15 years and his main area of interest being the voice, airway and swallowing disorder. So we welcome you.
Thank you so much. Thank you so much.
We also have with us Dr. Thiru. Sir is BBS Diploma in Otolaryngology and DNB ENT. He is a pediatric otolaryngologist who practices at the Rainbow Children's Hospital at Chennai. He is a member of the undergrad board of studies. He is the lead guest faculty at ASIM 2019, Sir Satya Sai Medical College. Sir, we welcome you. I would also like to welcome Dr. Prakash Bhuminathan, sir, who is the professor and head, the Department of Speech, Language and Hearing Sciences, Sir Ramachandra Institute of Higher Education and Research. Sir is a PhD and a member of the expert committee at the Rehabilitation Council of India. Sir has also been awarded the Best Paper Award for Speech Acoustics, National Symposium on Acoustics, and Mysore awarded by the Acoustical Society of India. Sir, we welcome you. I would request all the sirs to please take over for the session. Sir, over to Manish, sir.
Very pleased to be a part of this thing. I've joined a little bit late, so I would request other moderators to start the session. I'll join shortly with you. No problem. Hello. Dr. Rakesh Srivastav, I think, is starting the surgery, and I think he will introduce us to the case.
I think we are having some demonstrations of pre-recorded videos of procedures like video laryngoscopy and acoustic analysis. Hopefully we have something. So we will take on and we'll proceed as we progress with the video demonstrations. Over to Dr. Nilanjan.
Can someone hear me?
Yes, sir. We can hear you.
Great. So what we've got lined up today actually is a sort of instructional course of how procedures are done. And to coordinate all of this, we have Nilanjan. Nilanjan is a good friend and he works in voice and swallowing clinic in Dinath for some time now. What he's done is he's taken time and recorded demonstrations of each of these procedures. And he will sort of take us through and we will be free to ask him questions of how it's being done, what are the special points. And he will tell us about exactly how the procedure works. So, Nilanjan, what do you have for us to begin with?
Nilanjan, sir, just unmute yourself. We can't hear you, sir.
So thank you very much, Datta sir. What we'll be demonstrating today are video laryngostroboscopies, a high-speed laryngoscopy, fiber optic endoscopic evaluation of swallowing, a transnasal esophagoscopy, and a voice analysis, all done previously, 2 to 3 days back. We have recorded these sessions, and then the sessions are being broadcasted. So what is going to happen is I and all the other people who have been doing these scopies and analysis, they have explained the procedures during the procedure itself. So I'll be here and I'll be free to answer any question which comes in from any of the delegates or the faculties. All right. So I think we can start off the first video recorded session of the video laryngostroboscopy. Dinesh, can we start it?
So hello everyone, my name is Dr. Fayal. I'm a laryngology fellow, and this is Dr. Mihir. He's an ENT resident from the Department of Laryngology in Dinanath Mangeshkar Hospital and Research Center. Today we'll be performing a video laryngostroposcopy with a flexible scope, and the procedure will be done under local anesthesia. So for this procedure, we are going to use 4% spray lignocaine. We spray the nose because that will be the passage of the flexible laryngostroposcopy, and then the oral cavity for gag reflex. Open your mouth, please. Say okay, that's it. Then I'll spray the nose. So for the video stropholaryngoscopy, we will be using a surface electrode connected to a microphone that will be fixed to the patient neck over the thyroid cartilage, either on the left side or the right side. The purpose of the microphone and the surface electrode is to pick the frequency of the vibration of the vocal cord in order for the machine, which we are using Pentax stroposcopy machine, to pick the frequency for the strobe light as well to show the mucosal waves. So for this process, we are using HD flexible laryngostroposcopy, and the recording will be through a foot paddle. So once the recording should start, then we just press on the foot paddle. So in this patient, we already anesthetized the left nasal cavity, and we'll start from there.
So traditionally, we have all learned doing these scopies through a rigid 8 mm laryngoscope, video laryngoscope, and along with that, we have to hold the tongue and do that. But in recent times, the chip and tip high definition.
Now we are at the level of the tongue base. At this point, we can ask the patient to open his mouth and protrude the tongue to examine the valleculae. So this is the lingual tonsils. This is the valleculae. And then we'll ask the patient to just put the tongue back and close the mouth. Then we'll advance the scope down. And now we can see the periglottic fold in the left side, in the right side. This is the piriform sinus in the left, and this is piriform sinus in the right. These are the vocal cords. Now, for examination of the vocal cord movement, we'll be checking for the posterior cricoarytenoid muscle, thyroarytenoid muscle, and the cricothyroid muscle in 3 movements. So first, we'll ask the patient to take a deep breath. Take a deep breath, please. Okay, then we'll ask the patient to say E to check for adduction. Okay, excellent. Then we'll ask the patient to say E from low tone to high tone. Excellent. And then we'll ask the patient to sniff for abduction of the vocal cords. Okay, excellent. So this is how we examine for the movement of the vocal cord from all the contracting muscles. Then this is ends the video laryngoscopy, and now we'll shift to the stroposcopy. Recording stop. I'm really sorry. Moshi? Now the stroposcopy will give a better resolution of the vocal cords. We can go even closer. And just to clear the scope, we'll ask the patient to swallow. Okay, sorry. Swallow once more, please. Okay, excellent. And now we'll ask the patient to phonate to check for the mucosal wave. Phonate, please. Say E. Stop. Press on the electrode yourself. Press strong. Okay, right. And turn slightly to the side. Okay, now phonate E. No, press more. No. No, I'll give another video for them then. Okay, excellent. And then that's end the stroboscopic examination for the patient. We withdraw the scope always under vision. And this completes the procedure.
So that's nice. And then Ranjan.
Yes.
Yeah.
What are we having next? Is it the high-speed laryngoscopy? Dinesh, can we have the recorded high-speed laryngoscopy?
Nilanjan, before we go ahead, just if there are some points about basic laryngoscopy, I think it's a very important procedure.
Hello.
You can just guide our delegates.
Yeah, what are the parameters observed? Yeah.
Hello. Yeah. So during a video stroboscopic examination, primarily we need to see the vocal fold mucosal waves, the vocal fold amplitude. Then these are the main two parameters which we see during. Then of course is the hello.
Yeah.
Hello. Yeah. If there are phase differences. A stroboscopic examination, of course, is very informative in terms of the vocal cords, the mucosal waves, which is probably the most important parameter that needs to be seen during a stroboscopic examination. Are there any questions from the moderators? Dr. Prakash, is there anything that you feel a stroboscopic examination should particularly, see?
Yeah. So I think what we could possibly highlight when we use a stroboscopy is just beyond the structure evaluation, we also have a little scope to look at the functionality of the vocal cords, the way the vocal cords are behaving when the person is producing different sounds. So when you use a flexible laryngoscopy, when you use a flexible scope, the oral cavity is left free, and so the person can actually produce sound as how he would normally do, with a little extra fitting in the nose, of course. So what you ask for is to sustain the sound in a regular manner, as how he would say, and usually the vowel E. And then to see the engagement of the thyroarytenoid and the cricothyroid, the relative variation, the flexibility of the muscle, you possibly can ask the person to glide from a low tone to a high tone, which would be like so high tone to low tone. So you can really see the vocal cords stretching and contracting, and that gives the idea of how the vocal cords actually can change the glottic shape as the person glides from a low tone to a high tone. We can do this in normal volume and in louder volume. And when a person is saying the same thing in a loud voice, the way the vocal cord, again, adduction force will vary because of the force, the pressure is increased there because the person is producing loud. We also can see laryngeal diadochokinesis by asking the person to interrupt the phonation periodically. Instead of having a sustained phonation as E, if we have E, 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 then the adduction, abduction, adduction, abduction, the diadochokinesis can be assessed there also. In case of certain laryngeal paralysis, especially superior laryngeal palsy, asking the person to sustain a loud voice on a single tone for a long duration, we can also observe drifting of the cords to one side. The paralyzed side will start, it will start sagging towards the paralyzed side. as the laryngeal weakness sets in, especially when you have a superior laryngeal palsy. So certain functional aspects can be assessed more, especially when you are having stroboscopy. Mucosal wave, as you highlighted, is very fundamental. Along with that, the relative engagement of the muscle, the way the vocal cords work and maintain the glottic shape, the vocal fold edge and the shape of the glottis can be very well assessed when we use stroboscopy. So those are some things which are very crucial, especially when you assess post-operative and functional cases.
So let me ask you a question, guys. Like, suppose I'm a laryngologist or I'm an ENT surgeon who's not yet decided to be full-time in laryngology. Would you recommend that I invest in such a device? Just, I am now comparing video laryngoscope or a stroboscope. What additional, is there any cost-benefit analysis study which is there, or something which can convince me that I need to put money into this?
Definitely, I think your decision making of surgery and how much recovery from surgery, assessment post-operative, you get a better judgment with stroboscopy. So as I told you, the functional, it's just not the structure which is so important. Of course, it is. Along with that, how much functionality can the person gain back and how quickly? So for that judgment, stroboscopy definitely will make I think it is the gold standard across the world. Stroboscopy is the norm for any decent voice clinic. And it is worthwhile to think of investing on a stroboscope, which is far superior in terms of giving the surgeon the perception of depth, the extent of the lesion, to some extent more than the video laryngoscopy. So definitely will be useful for a voice clinic.
I have one question.
Dr.
Prakash. Can we diagnose with the flexible video stroboscopy or by flexible laryngoscopy adductor spasmodic dysphonia just by like in my office I usually do the counting and two consonants like that. So what are the structured, like how you do it?
So spasmodic dysphonia, as you said, running speech is a preferred probe than a sustained phonation, especially adductor spasmodic dysphonia and abductor. To make that distinction very clearly, I would think when we have counting numbers or saying a standard set of sentence again and again, repeating it again and again, is possibly a good idea. And that if they have a lot of vowels in it, vowel-initiated sounds are more difficult for adductor spasmodic dysphonia, where you can see the tight adduction. And so running speech is what you should use. And for that, flexible scopy is more comfortable and is possible. If you have a rigid scope into the mouth and have a running speech, it's going to be difficult. People can manipulate and do it, but it's not the most convenient for the patient, definitely. So that way, I think it will do good. And stroboscopy again gives you an idea of the laryngeal contact, how much of the vocal cords are in adduction, how forcible it is there. And since it's in a slow motion picture, you can freeze it and you can also montage and see it in different phases. Definitely will give you more information than a VL scopy. Though muscle tension dysphonia and spasmodic dysphonia can be very well identified with a VL scopy itself, stroboscopy gives you a little more confirmatory feel of what you may, get out of the picture when the person is speaking these sentences under a strobe.
Dr. Prakash and Dr. Manish, questions for both of you is: do you all have how important, or how do you feel can a vertical level difference be assessed on a stroboscopic examination between the
May I? Yeah, I mean, because the stroboscopy picture allows a slow motion perception of mucosal wave very well. So I would not say that you get a three-dimensional look at it too well, but in spite of that, because of the relative movement of the chords to each other, you do get a perception of vertical movement very well. However, cannot compete with chiromographs and all those things to make out the absolute difference. But when you see a difference in the reflective nature of the vocal cord, how the mucosal waves is progressing in one cord in relation to the other, and with respect to closure also, a vertical assessment is quite much possible with a stroboscopy, much more than a conventional laryngoscopy. That's what I feel.
Yeah. Can I quickly share a slide which will give us a little procedure which I usually use for my,
oh, sure. Go ahead.
Yeah. Well, so is my slide visible? Is it visible, sir?
Yes, yes.
Dr. Nilanjan and
Yes, sir. Yes, sir.
okay,
Yes,
great.
sir.
So this is the procedure we use, and I think this we will quickly. So gross structures. We look at the vocal cords, vocal process, and interarytenoid space. That's the first level of inspection. Then the second is the glottis, the space between the two vocal cords. So you look at the tracheal rings. If it is visible, but not really, it's not any information for us. But glottis, the shape of the glottis is what you may look. And the second, above that is the false vocal cord. And then you look at the other structures around. So you start focusing on the vocal cords, the space between the vocal cords above, and then the peripheral area. So this is all for the gross structures. And then beyond that level, level 4. So this sort of visual inspection going from the focus point to a more diverse view allows us to look at several aspects of the thing. Functionally, these are the aspects which you should assess. So it is closure, symmetry, periodicity, amplitude, mucosal wave, non-vibratory portions, and the ventricular folds. So this will give you an idea of how to make a functional assessment. For the closure pattern, we use the Diane-Bless classification. That's a pretty standard one. Allows you to locate what sort of glottic closure pattern is used. So this is a montage image which we can use. We can freeze at different points, get the visual things. It's an example of a longitudinal gap. This is a double gap. This is anterior, posterior gap. And this is when you have bowing of vocal cords. The level difference can be slightly seen in this also. And this is how you need to look at symmetry. It's basically mirror image of right and left. This is an example for symmetric and asymmetric vocal cord vibration. When you look at the montage images, you'll be able to track. This is periodicity, how regularly is the right and left vocal cords coming in and they're moving out. You probably require more frames for you to look at the full glottic cycle, or 2 glottic cycles you need to see for you to see regular vibration. This is aperiodic montages. Amplitude, the extent it is traveling from the center point to the lateral edge. And the mucosal wave from the lower edge of the vocal cord coming to the lateral surface and then on the superior surface of the vocal cord, how the mucosal wave travels. Non-vibratory portions, are there any adynamic segment in the vocal cord itself or anything surrounding? Hyperreduction can be seen with the false cords. So these are some of the things which we should remember. It's not a real-time measure, and you're visualizing through an optical device, so there could be issues with the optic device. And what is a speech sample you are looking at? And there could be individual variability in making these differences too. Okay, so that's quickly to give you a run over of what might we do when we assess using stroboscopy? Something which I pulled out from what I have used it in the past. So I'm sorry, it was a quick unprepared.
So Nilanjan, now that we've seen stroboscopy and we've seen laryngoscopy, what do you propose to show next?
Yeah, so well, the first we have learned of the various advantages associated with the stroboscopy now. Now, what has to be understood is there are some disadvantages inherent. Stroboscopy, since it's finally an illusion, wave-to-wave variations can not be picked up on a stroboscopy. So this is what we propose to show next. It's a high-speed laryngoscopy, which is a more accurate tool in diagnosing wave-to-wave variations. It is a camera which records each and every wave that is occurring, and that is why this is, in terms of very fine voice disorders, it's an extremely efficient tool. I think, Dinesh, can we have the video of high-speed laryngoscopy up next?
The second.
Dr. Puneet, I think, has demonstrated a high-speed laryngoscopy. No, this is the...
Puneet, 1 second, sir.
Yes.
It is that number 4 video. Dr. Puneet, number 4 video.
So can high speed be done with nowadays with a flexible scope, with a
Hello,
normal
I'm
spokes,
Dr. Puneet.
or
Hello, RCS Department of Laryngology, Dinanath Mangeshkar Hospital, Pune, India. Today I will be demonstrating high-speed video laryngoscopy. The reason to choose high-speed laryngoscopy is that in order to overcome the disadvantage of stroboscope.
We will get to
what
all
are the
this
disadvantages?
over,
In order to achieve mucosal wave in stroboscope, we need quasi-periodic waves. That means patients who have got diplophonia, as in case of plica ventricularis, vocal tremor, vocal breaks, and also in vocal onset as well as offset, stroboscope will not be able to show mucosal waveforms. In order to overcome the disadvantage of stroboscope, we will be using high-speed video laryngoscope. So in our department, we have high-speed video laryngoscope, which belongs to K Pentax company. We use halogen as a light source, and we use high-speed camera, which is fast cam MC 2.1 model, and we also use endoscope, which is a rigid 70-degree endoscope of K Pentax SN1610 model 19106, and we also use K Pentax color high-speed video system standard software for the same purpose. So halogen light source and the high-speed camera setup and the software which belongs to K Pentax company. So I will be demonstrating high-speed videos laryngoscopy. Mr. Chinmay, who is a SLP specialist, has volunteered for the procedure. We will be doing this procedure under local anesthesia. We will be using lidocaine spray for the same procedure. Okay. So we will be doing the procedure. I have already anesthetized our volunteer with 15% lidocaine with 5 puffs of spray into the oropharynx and then into laryngopharynx. So we will be doing the procedure. We will be using rigid endoscope. We will generally we will ask the patient to protrude your tongue out. So here some centers ask the patient to hold the tongue themselves, but in our center we prefer to hold the tongue so that it gives better control on the scope. Yes, can you say E? Can you say E? Cut. Yes. Once the patient, once we have reached the rigid endoscope across the uvula, we need to elevate the scope in order to visualize the epiglottis and the true vocal cord. And then we ask the patient to phonate with E. And once we achieve good enough phonation, we ask the assistant to press trigger button so that high speed camera is activated. Can you say E, longer E, trigger? Yes, thank you. So after triggering, this is the video which we will achieve. So here, as you can see, onset of phonation is easily demonstrable. You can see first 2 to 3 waves which shows onset of phonation. This video is recorded at 4000 frames per second, hence the video is slower than what we usually record, which is at 2000 frames per second. So you can see there is initiation of phonation. Now steady state of amplitude has been achieved. You can see very good lateral excursion and each cycle resembles the next cycle. As we triggered in the initial phase of phonation, offset of phonation is not recorded in this video. So the advantage of high-speed videography is that onset of phonation, offset of phonation can be recorded in case of diplophonia and in case of vocal tremor and then vocal breaks. This has got more value. And this is always complementary to stroboscopy. This cannot be used as an individual examination tool. Thank you.
Yes, that was quite informative. Dr. Prakash, any views on high-speed laryngoscopy?
So I have no personal experience in using it. We don't have it in our clinic, but I think DMH has the, I think it's one of the best places where you get all these things. So that's great. Only thing is we don't have sound for analyzing when we have high speed. Usually it is only the image. And so that is one important thing we should, consultants should remember, that you will not have sound to coordinate with the actions. So as highlighted, the onset and offset is very clearly observed. And in between, if there are any voice breaks or intermittencies in the voice, the high speed will give us a little more way what is actually happening at the laryngeal, the dynamics there can be assessed better. That's the only thing. And it consumes a lot of space because it's high speed, so automatically the data storage and the backup you require and retrieval
is huge.
Yeah, so it is quite voluminous in that sense.
Approximately each examination, just to go on, approximately each examination is roughly around 2 GBs. So that's quite a lot.
So basically 6 seconds video would convert into around 3.5 minute video, sir. So offset of phonation, it will be difficult to record because we will be concentrating only the initial 3 seconds of recording. And also in cases where got diplophonia like plica ventricularis or vocal tremors or short vocal gestures, high speed has got more value than stroboscopy. But the only problem is we cannot use it as a one tool. We have to combine with stroboscopy, and then we can add additional value of high speed to the stroboscopy to enhance our clinical assessment. And also we have to use other objective methods of evaluation like voice analysis, all those things to complementary tool to this high speed video, so that we can take collective decisions. So the disadvantage is we cannot use it it as individual tool. And also the machine what we used in our center, which is high speed camera, it is no more available commercially. So because of less clinical application, the company itself has stopped producing. So this is also one clinical drawback, I could say.
Can I just play the devil's advocate here? So I think Nilanjan or someone can just, since you have been using this device, it's quite evident it's got a large cost. I am sure you need to recover this cost. I'm sure there's someone who pays for this test. Now, when you again at this stage want to say or talk about the investigation, how do you justify an increased cost? What outcome measures have you shown which change by using this machine, or literature shows that it has changed once you start using high speed? Ranjan, you are muted.
I think in some I'm just putting in before they speak. I think there are some odd situations in surgical conditions, like post-op cases. You have done a good surgery, but and the stroboscope is pointing out to all the right parameters, yet the patient is not comfortable with the voice. I have referred personally such cases to one or two cases to Dinanath, where they could do the high speed and make out whether there was any tethering of the or a dynamic segment which was not being shown by stroboscopy. I think it can have a good this thing in assumption of scars and sulci where you're not sure of surgery. So these are 2-3 ways that I've always thought that high speed as a standalone tool later on to assess whether you could actually operate on this adynamic segment or not could be more helpful than stroboscopy, because you find the visuals quite clearly that way in a slow motion. I mean, when you play it slow.
Absolutely, Manish. And further on, even for
just to add on, Nilanjan, in that there is a newer investigation which is known as UHRCT, ultra high resolution CT scan, which has especially in patient with called palsy, whether this helps in to look. Sometimes it is very difficult to look at the posterior commissure area. So how much is the posterior glottic gap is there? For that, they have come up with a 0.3 mm sections at the level of just above the arytenoid, then at the level of arytenoid and below the arytenoid, so that we'll know exactly whether that patient requires a arytenoid reduction or not. So it has been studied by one of the Japanese workers, scientists. They have published recently, and they've used it for diagnostic purpose. That is a ultra high resolution CT scan. It's now available in India also, UHRCT, but not being used for this for such this vocal cord palsy and other patients.
So recently we have done a study of high-speed video laryngoscopy in vocal cord palsy, pre-fat augmentation and post-fat augmentation, and another study wherein to show voice outcome in patient who have gone cordectomies. Again, this is also medialation after cordectomy, and in that open coefficient has been evaluated in high speed, and open coefficient cannot be assessed in other methods like in stroboscopy, but with high speed endoscopy open coefficient can be assessed, and it showed significant improvement. So we can use this as an objective tool to assess how well the outcome is post surgery. And Dr. Gandhi sir has published 2 papers based on the findings. One is pre and post operative high speed video laryngoscopy in unilateral vocal cord paralysis following autologous fat augmentation, and another is high speed video laryngoscopy in early carcinoma patients following transoral CO2 laser. and this is published in European archives, and fat augmentation is published in American journal. And both the study showed with high speed we can calculate open coefficient, and we can add objectivity in evaluation with high speed. And also the present machine also helps us in calculating rather demonstrating chymography. So the present machines we can evaluate speed as high speed video as we can record, as well as we can assess chymography also. So we can use it for both purpose. And it has got less clinical value, we agree, but it has got more value in research purpose than clinical application.
Hello.
Hello. Yes, sir.
Just as an extension, am I audible?
Yes, sir. Yes, sir.
Yeah. So just as an extension of what Dr. Manish was saying just now, I feel, just to answer Dr. Datta's question, even for very early growths, very early tumors, which wherein visualizing the mucosal waves in slow motion might give us a hint as to an underlying malignancy, I think high-speed laryngoscopy is quite useful. Moreover, we have in the past had a rather unconventional use of high-speed laryngoscopy. You see, in patients of total laryngectomies, they have got a cricopharyngeal segment which is dynamic, which keeps which is probably the part which enables the patient to voice out phonate. That is a segment which can be visualized on a high-speed laryngoscopy. The waves noted, and then probably see the dynamicity. There's no study so far which I have seen which has measured the dynamicity of the cricopharyngeal segment, but then definitely that is something which can be looked into. So that is a patient post laryngectomy not having a good adequate voice, probably a high-speed laryngoscopic visualization of the cricopharynx, the neopharynx that is, can give us a measure of what might be going wrong. So that is another clinical application that probably can be looked into.
And right now we are assessing if scar formation can be picked up early with high-speed camera, so that any modification in surgery can be thought of. So this is also presently we are thinking in this sense. So again, this is more in terms of it would help in research purposes rather than straight-ahead clinical applications.
For day-to-day practice.
Yeah, Dr. Nilanjan sir, can we put next video?
Yeah, so so the next video we can show the voice analysis of a patient. Now, since we are on the subject of voice still, so I would request Dr. Prakash to come in there because he's a better expert at it. So voice analysis, I think, has been demonstrated by Vrushali Desai, and I think we can play the video up next. It's a multidimensional voice program. And Dr. Prakash, are you here?
Yeah, very much. Yeah.
So I think we can play the yes.
This is the voice analysis system, that is the multidimensional voice program by K-Alimetrics, and it is used to compute the various acoustic parameters. So it is a semi-automated system where we ask the patient to phonate, and then as the signal is recorded, it will present with the radial graph. He's our patient. I'm just going to instruct him for the analysis now. You have to take a deep breath, and then you have to say E softly for as long as possible in a comfortable voice. Okay? You can begin now. take 3 samples for each vowel, that is A, E and O. And once the signal has been recorded, as you can see here on the screen, then we can process the signal. This particular graph that you can see here gives you parameters of frequency perturbation, amplitude perturbation, noise, tremor, and voicelessness. As we can see in this particular graph, the amplitude variations are a little high and the degree of voicelessness is a bit high. Otherwise, most of the parameters are within the normative circle. After the various graphs have been computed, we also get a particular printing or a report format where all the parameters are quantified in their values and compared with the normative ratio as well as the standard deviation. All these, since this voice analysis is not invasive, we can do it multiple number of times. We can do it pre-therapy, pre-operatively, and repeat it at every interval when the patient comes for follow-up.
Yeah. So just to give a little overview of voice analysis, as all of us would agree, voice is so complex and so it requires multi-dimensional or multifactorial assessment. So it's just not enough to hear the voice perceptually. What you cannot pick up through the ear normally is picked up through more refined measures like acoustic analysis. So that is one of the first advantage of using things. So because our difference lineman of hearing is very, very short. So subtle variations in frequency, subtle variations in intensity parameters are not usually processed by the ear. So those subtle things can be picked up. And another biggest advantage is the unreliability of the ear, the differences between inter-subject, clinician A versus clinician B, or clinician A versus time 1 versus time 2. Those uncertainties and unreliabilities can be overcome by having more a standard procedure using an acoustical. So you get pretty reliable measures when you are repeating the analysis also. So that way it is more dependable to get acoustic measures. So these two are the major advantages of using acoustic analysis. The disadvantage of acoustic analysis is we should understand the limitation of the system. So it is very important that what you feed into the system for analysis, so will you get your output. So if you have a bad recording, then the output, whatever the metrics, whichever you may use, may not necessarily give relevant clinical, insights. So it is very important for us to make a good recording. And as much as we think of the software and its capacities and the different metrics, if the recording is not taken care correctly, then there is no real value of acoustic analysis. When we talk of recording, 3 important things we should remember. One is the microphone and the sound card, the external gadget, and so a condenser microphone and a good sound card with a good quantization and digitization of possibility is important. Second is the room ambience, sound. If not acoustic treated, at least sound free, which is very important. You do not want to have any other low frequency sound sources in the recording thing, and or any external noises which is coming. The third important thing is the compatibility of the recorded software, wherever you are storing, whatever format you are storing, to the analysis format. Okay, like for example, the demonstration was of CAPE and TAX, and so it analyzes only in NSP format. So if you have recorded in some other external gadget, and then you feed that into the CSL system, there is transmission variations, and sometimes this analysis cannot happen, and you may not get relevant measures. So these are some things which clinicians should remember when you are applying acoustic analysis. The second important thing when you are doing is, what is the metric and what is the limitation of that metric? So usually clinically, fundamental frequency related measures, intensity related measures, and the quality related measures is what we are assessing. In fundamental frequency, all types of voices, we will get some amount of fundamental frequency. But perturbation measures, when we go either for frequency or intensity, if the sound signal is not periodic, acoustic analysis cannot be applied on that. So you may get a jitter value or a shimmer value which is way beyond the norm. That may be because the fed-in data itself is incorrect. So that's where the clinician judgment is very important. So when you make the recording, the most periodic segment has to be highlighted, and only that should be subjected to analysis, and not the entire recording you may do. So even 10-20 millisecond is enough to get all different voice parameters which is available to us in literature. So we don't really require to have very long recording. So 3 seconds is what usually record, and that 3 seconds, 30 to 40 millisecond is highlighted. The most periodic segment. So that can be done by visual judgment, visual analysis of the waveform. You can subject that to a long-term average spectrum, get this spectrum analysis. Based on that, you identify the most reliable portion which you can analyze other frequency and intensity perturbation parameters. So that is the second important thing. So not subjecting the entire recording to analysis is important. Applying clinician judgment on which segment should be analyzed. The third important thing is, at that day, what the person is performing is what you're getting. So when you are asking the person, so the instruction you give, the recording comfort you have provided to the patient, and the listener, the clinician makes a judgment. Is he doing it comfortably, or is he doing it with a little extra effort, or all that has to be combined along with the values which you're seeing. So just based on the values, you don't make decisions. You will make on the comfort of the procedure itself. Though we think it's the most non-invasive, comfortable, just in front of a mic. The mic itself is enough to increase the anxiety for the person. You sit in a sound-treated room, keep a mic in front, and suddenly ask the person to say something or say that itself. So familiarity of the procedure, making the person calm and getting the most representative sample for analysis will add value to clinical use of this tool. These are some things which clinicians should remember while we employ acoustic analysis. And just based on acoustic analysis data, we really cannot make a diagnosis. We augment the more physical parameters. Those are measurable parameters. Those do not change over time or do not change with differences in people who are measuring. So that sense is where we should apply acoustic analysis. And all of these are based on linear analysis, and the world is changing towards looking to more non-linear analysis now. That's yet in research stage. We don't still know most clinically reliable non-linear measures yet, but it will come in the years to come. That will be the way to go in acoustic analysis, I think. So these are some initial comments. If there are some more questions, I can answer.
How do you, Prakash, do you have to comment on the various different types of softwares and hardwares available for the same? We know the authenticity of NDVP, but there are so many measures that other people use, and there is so much of confusion. So could you just walk me, Dr. Speech, Pratt, all these things that are available? How would you give a very brief single comment on each of them and their comparisons?
Thank you, Dr. Manish. It's a very important question. Many times we are also, the market provides us a range of softwares. All of those are pretty okay to use as long as we have got quite a decent recording system. The algorithms are pretty much close. Many of these patented softwares come with a pre-recorded database also. So that gives us some normative comparisons. So that is the advantage of having any of these patented systems. But otherwise, most of these softwares are pretty reliable. They have published their data in all reputed journals, so they give fairly reliable clinical values. So it's fine to use any of the software. But what we need to invest is on the recording environment and the recording device. The hardware is the crucial part than the software itself. There have been studies comparing these softwares and things. They're all pretty okay. They give fairly. The caution we have to do is for a patient A, we have done a pre-recording before a procedure or before a surgery or before treatment therapy in using a software X. Then post comparison should also be on the same software X. It should not change. That is the only caution we have to. In terms of the goodness value of all these software, they're pretty much standard. We can use any of them. Does it answer your question, Dr. Munjal?
Yes, absolutely.
Sir, good afternoon. This is Dr. Puneet, fellow at Deenanath Mangeshkar Hospital. Just to add another question to Dr. Manish's question, for junior consultants or fresh laryngologists, can we use free software which are available for voice analysis, and how reliable they are? And you told that recording system is more important. So which type of recording system should we invest in as a beginner?
So any software can be used as long as you have defined the metric. So if you are interested in measuring fundamental frequency, jitter, shimmer, or whatever metric for your study or for your clinic, you need to look at the algorithm and see how they have computed these. And if you know that's pretty standard, you can use it. There's no problem. So software per se, there isn't issue as long as you know what is the definition of that metric and how that metric is being computed by that software. That's enough. Hardware, good quality mic, ideally condenser mic is better. And if you do not get a condenser mic, dynamic mics are also fine, but you need to keep checking whether the mic quality is pretty okay. Mic to the sound card compatibility, the device where you are measuring. So it could be the wire, it could be the quantization factor of the sound cards. So that is where you need to invest. So these days, even our phones give good recordings. So I think if you buy a decent laptop or a decent computer with a good spec, that's pretty standard. Recording environment is important. So make sure there is no external noises. There are no vibrations inside the room, low frequency capacitance noise, which can come from tube lights or, if we now everywhere it's going to LED lights don't make much noise. They don't have noises. So those are pretty standard we can do. Earlier, those tube lights used to give a humming noise. If you have other devices, other computers working in the same room, and if they are on, that may have some noise. So these are some of the noises. So when you make a recording, you have to just keep the mic on and just see whether there is a straight line and there are no variations in that straight line you're recording. And then when you are saying the sound, how does the waveform look like? So that gives you a little comfort that you know that you are having a reliable signal for analysis. Then what you analyze it is fine. That's why we do 3 or 4 recordings. As Vrishali said, we ask them to repeat 3 times. And we take the most reliable thing. And that's, again, a clinician judgment.
Thank you, sir. Thank you. That's all. Not many doubts which we had. Thank you.
Thank you.
Is Dr. Datta here? is Dr. Duck. I think we'll move on to the video demonstration of fiber optic endoscopic evaluation of swallowing. I would like to say a few words before we start that off. Fiber optic endoscopic evaluation of swallowing has been in force since the last 20 years or so, a little more than 20, 25 years or so. And it has become an excellent tool for the diagnosis of oropharyngeal dysphagia. Now, FEES has its own limitations that understanding oral dysphagia or oral phase of swallowing is quite limited. But then for pharyngeal dysphagia, for the movements that occur during the pharyngeal phase of swallow, the oropharyngeal phase of swallow, FEES is an excellent tool. We'll just go on to the demonstration of FEES, and then I'll be happy to answer any questions that come along. Dinesh? Dinesh?
Yes, sir. Tell me, sir.
Can we have the can we share the video demonstration of FEES?
Which one, sir? I'm just sharing the full folder. This one video, sir?
Yeah, I believe so, yes.
So now we begin the demonstration of the transnasal esophagoscopy.
No.
The most common indication.
I think this is the TNE. Can we do the other one, the other one that I...
Sir, tell me which one, sir.
There are only two recordings that I did. So one is the FEES. Since this is not the one, the other one. Yeah. So
this one, sir?
That one is TNE, the first one. Yeah.
First one, yeah, second one.
Kiji ek minute, we'll just...
Hello, I'm Dr. Nilanjan Bhaumik. So now we begin the demonstration of the transnasal esophagoscopy. Now, the most common indications for performing a TNE or transnasal esophagoscopy is dysphagia. Dysphagia, that too when the patient pinpoints to it being a low dysphagia or an esophageal dysphagia. Again, laryngopharyngeal reflux, screening for head and neck cancers, then even patients.
This is not the one, the other one.
Hello, I'm Dr. Nilanjan Bhaumik, and today we begin the swallowing session by a demonstration of FEES or fiber optic endoscopic evaluation of swallowing. Now, FEES is out here in our institute. We use this digital swallowing workstation to do a FEES. This is the monitor. This out here is the central processing unit, and this out here is the processor. It's always advisable to use a chip-on-tip camera laryngoscope for doing FEES because the clarity required is immense. Now, this is the laryngoscope that we use. This is a 30-centimeter laryngoscope with a 3.9 millimeters diameter and a 4.1 millimeter tip diameter. During a FEES examination, we feed the patient all consistencies from liquids, semi-solids, pureed feeds, and finally solids. This out here are the feeds which are colored with food dyes. We have used biscuit out here, curd, banana, milk, and of course thin liquid as water. The patient in whom we are undertaking a FEES today is a gentleman, young, who per se does not have any neurological or oncological history. He just complains of choking on feeds or having cough on feeds, especially so on solids. His clinical examination has proved to be normal. So we're just going ahead with a FEES examination to see if there is anything in particular in the oropharynx which is causing his dysphagia. म्हणजे फिजिओथेरपिस्ट तुम्हाला माहित आहे काय करतात फिजिओथेरपिस्ट करतात मसल्सला काही प्रॉब्लेम असेल तर ते तुम्हाला एक्सरसाइज व्यायाम देऊन ते ठीक करतात सॉलिंग थेरपिस्ट आणि स्पीच थेरपिस्ट म्हणजे तुमचा आवाजाचं जे मसल्स आहे तुमचं गिळण्याचे जे मसल्स आहेत ते तुम्हाला एक्सरसाइजेस देऊन काही प्रॉब्लेम असेल तर ते नीट करतात ओके सो व्हॉट वी प्रेफर इन आवर इन्स्टिट्यूट इज ऑलवेज टू डू fees examination, having an ENT surgeon as well as a swallowing therapist alongside. What happens is it's such a dynamic evaluation that the swallowing therapist at that very moment can devise therapies, and sometimes we can implement those therapies during the fees examination itself. So we go on and start. We also need a person alongside who can feed the patient or who can give the feeds according to what you require. So there's usually the patient, the ENT surgeon doing the scopy, a therapist, and another person to help you feed. Now we begin the scopy. Always remember, a fees examination does not require anesthesia. We do not use sprays. We don't even use local anesthetics in the nose. The reason is it can go down into the pharynx and interfere with the sensations, and probably you might get wrong readings. So we begin the scopy. Let's do a quick nasoendoscopy to have a look as to which nostril or which nasal cavity is roomier so as to negotiate the same. This is a relatively longer scopy. So the patient needs to be comfortable. And remember, the patient is not under any anesthesia of sorts. The patient needs to be extremely comfortable. Yes. Aram se. Yeah. So once we have entered into the nasopharynx, we need to ask the patient to repeatedly say E, E, E. E, E, Mana Parat? E. Mana Parat? E. This is to note the velopharyngeal competence during speech. Similarly, we also need to ask the patient to swallow a few times to see whether the patient's velopharyngeal competence is good during a swallow. Don't think about a gaya, aunda gaya. Aunda gaya. Parat ekda aunda gaya. Very good. Ata nakane श्वास घ्या please. नाकाने श्वास घ्या. मी हळूहळू घशात जातोय. नाही, मागे जाऊ नका, मागे जाऊ नका, मागे जाऊ नका. नाकाने श्वास घ्या. रिलॅक्स, रिलॅक्स. नाकाने श्वास घ्या. तोंड उघडू नका. नाकाने श्वास घ्या प्लीज.
लांब लांब श्वास घ्या. लांब श्वास घ्या. म्हणजे ठसका येणार.
So once inside the oropharynx, we need to see the vocal cords, the pharynx at rest, subsequently the vocal cord movements by asking the patient to again say E, E, Mana, Mana, E. Then ask the patient to conduct a few dry swallows. एक दोन वेळा औंढा गया, गया. And see for the pharyngeal movements, the laryngeal elevation, gaya. And also the presence of a whiteout, like the aunda gaya. Whiteout is the time duration wherein the entire tissues collapse against your scope and the light comes back into your scope, obliterating any vision at that point. This is part of a normal scopy. Aunda gaya. The base tongue propulsion and also the epiglottic retroflexion. Ekda gaya. Subsequent to this, we need to go ahead and assess the patient. From the patient's present coughing, it's quite apparent. Good gag reflex. Okay. So rather than disturbing him right away, it's always preferable that we can assess his cough reflex a little later. Pani there. We start off the feeds always with water, because water, if at all is aspirated, it's fairly safe for the lungs. So what is given is a small quantity of water We see it from view. What we need to do is advance the scope into the laryngeal vestibule, see for any remnants of colored fluid either within the laryngeal vestibule or in the subglottis. See for any remnants of feed or fluid out here in the pharynx, the pyriform fossae, and then repeat the same. परत थोडं पाणी द्या, थोडं जास्त द्या please. This is how a normal swallow should be. The bolus just comes for a fraction of a second into the pharynx and then disappears from our view. Milk. Now what you can see out here is something called channeling. Something called channeling, where you'll see that the milk encircles, or rather goes around both the sides of the epiglottis and drops into each pyriform fossa. This is called channeling. At the same time, we need to just go down, see within the laryngeal vestibule, look for any residues, look for any penetration, aspiration, and then go on to semi-solid feeds. Dahi da. So now we feed curd to the patient. You can see that the patient within one or occasionally within two swallows can clear all the feeds, all the food given from his pharynx. So we move on to soft solids. Soft. Parat. The passage of the food from the oropharynx into the esophagus is actually obliterated by a whiteout, and that is how it should be in a normal swallow. Biscuit. We move on to solids finally. What we usually like to do after this is give the patient slightly larger water sips, pani da, direct da, and see how he manages to take it in. See, at all times when the patient is asked to swallow or when the patient is taking in the feeds, the scope should be maintained behind the uvula. It's only after the completion of a swallow do we advance the scope into the laryngeal vestibule, have a look within the laryngeal vestibule, see for any residues in the pyriform fossae or in the vallicula, and also see for aspirated material. In this gentleman, there is none. It seems to be a good, effective swallow. And finally, we just go ahead Sorry.
Continuously
She's got a pretty sensitive cough reflex, and I don't see any reason to irritate it further. And so that completes our swallowing evaluation by fees. Thank you.
So that was a fees examination. Any questions from these chairpersons, moderators? Any questions?
Yeah, I would like to really comment and first comment on the way you also extend these things in the past into the, although it's not part of a regular fees examination, but you have always gone ahead and even seen the cricopharynx beyond that and that thing. So, I mean, would you say that the assessment of, especially suspected cases of globus, do we need to go further, also assess cricopharyngeus, muscle, and also if that is possible with regular fees endoscope? Like to know.
Yeah, that's an excellent question, actually, Manish. A regular fees endoscope is usually a thin bore endoscope. The reason is because it's a long endoscopy and automatically you require a longer time and the patient needs to be comfortable. So these endoscopes are usually not equipped with an insufflator. Now, having said that, there are some patients in whom we can do an excellent esophagoscopy and a cricopharyngoscopy with your regular routine laryngoscopes, and you get to know the information. But that is not the norm. There are a lot of occasions wherein visualizing the esophagoscope, even the cricopharynx. The cricopharynx is a relatively easier deal because when we ask the patient to swallow, especially in patients who have reasonably normal swallows and good laryngeal movements, the elevation that I mean, the higher laryngeal excursions, usually the cricopharynx is well visualized even with your routine flexible laryngoscope. The same can't be said for the esophagus, but then the cricopharynx is well visualized. On the other hand, in patients, say, for example, a patient who's undergone radiotherapy or a patient who's having cricopharyngeal dysfunction, a flexible laryngoscope may not be always the best instrument to evaluate the cricopharynx, the esophagus too. So an insufflator probably would be far more helpful in those cases. But then there's no harm in trying, as I always say.
May I ask a question, Dr. Nilanjan? My colleague Lakshmi works more, I think in the afternoon she will be talking. So how would this fees be, would it be, the application be different when you have neurological reasons for dysphagia versus more mechanical lesions like, an injury or post radiation? So would you think fees will give us some insights in making distinctions between these two, and will the surgical decisions be any different when you have to make some surgeries for correcting swallowing issues? Will there be any difference?
Absolutely. So the fees in itself probably as a procedure does not change a lot, be it for anatomical impediments or be it for neurological causes, muscular causes. It does not change a lot. But then the clinical examination initially prior to a fees, what probably I have failed to mention is a good clinical examination is always a necessity prior to a fees examination. So good clinical examination, especially in patients who have, say, had head and neck surgeries, oncological cases. This provides a lot of insight to what you might find on a fees examination. And it's also possible that some of these patients, especially the oncological patients, may not require a fees examination always. A clinical assessment itself could suffice, at least for the time being. On the other hand, a neurological patient almost always, because they have got pharyngeal issues more commonly, almost always requires a fees examination to ascertain what exactly is going wrong there. The oncological patients, especially, they have more of an oral issue, for which probably, a fees examination may not always be an appropriate tool. So surgical decisions, again, well, they are based more on the fees findings rather than what the patient's history has. So probably surgical decisions may not alter tremendously unless and until there is some previous history of, say, radiotherapy, as you were saying. So radiotherapy and these are situations wherein probably you might not want to go ahead with a surgery. But then most of these patients, be it neurological or be it oncological, are usually good candidates for therapy. Surgical decisions and surgical interventions are required in a very small proportion of cases, actually. It's only for those patients having cricopharyngeal dysfunction that we think surgery is more of a necessity. Otherwise, therapy usually is the first line of choice and usually works very well too.
So prophylactic exercises, in fact, we do several things before the treatment procedures are started itself. So fees examination before, during and after, is that the way you to work, or is there, when do you recommend a fees examination ideally? Only when you start thinking that there is going to be, there is a swallow concern, only then? Or when you position a patient for a treatment procedure for certain things?
That's an excellent thought again, because this is what happens. So there have been studies which have shown that prior to head and neck surgeries, if you do even neurological surgeries for them, if you do a fees examination and then follow up that case, you have an idea as to what is going to happen. These patients usually do better than the patients who you see just post-operative. That said, since most of swallowing is a referred practice, it depends a lot on the referring surgeons or the referring physicians as to whether they would like to send across patients to you pre-operatively. Now the education has started reaching out, and a lot of oncologists have started referring, oncosurgeons have started referring patients pre-operative. But so far, we have been primarily doing patients who have come after the onset of the problem, and probably after a surgery or probably after the neurological event. What we try to do is, during the fees examination itself, we always have the therapist alongside. Rushali is there with me on all fees examinations. We always try to give some sort of therapy and see what effect it has on the bolus flow and whether the patient is able to swallow better. And that is something we can visualize real time. And then the therapy is guided a lot based on just that intervention that we practice during the fees examination itself.
Thank you.
For me, it is one of the most important parameters in post-op rehabilitation, of course, for therapy, as you said, but also people who are on Ryle's tube feeding and post-stroke. It's now a norm in our hospital that if they have been on RT feeds post-MCA infarct or due to a bulbar palsy, pseudobulbar cause, and when the neurologist wants to evaluate whether the person can now be subject to oral feeds and all, so we come in very importantly in that, and we do perform this, and it's been very helpful so far in recommending transition of a patient from an oral pure nasogastric feed tube diet to a oral initiation. And I find it very helpful. We have got a good record on that advice, and it's very helpful in that case for us.
Absolutely. Post-stroke dysphagia and post-stroke aspiration risk and post-stroke mortality because of aspiration is huge. So a fees examination post-stroke is probably it's a very good idea. Uniformly.
Sir, also can you add point on modified barium swallow and fluoroscopy? How would it help us clinically to evaluate swallowing?
So we don't do a lot of video fluoroscopies and video fluoroscopy, but then theoretically video fluoroscopies have been known to evaluate the oral phase of swallow substantially better than a fees examination. Then that's because we don't see the oral cavity in fees examination. We can just gauge from the movement of the boluses into the oropharynx as to what might be going on in the oral cavity. But then oral residues, stasis in the oral cavity, these are things which are far better seen on a video fluoroscopic examination. There are studies which have evaluated aspiration assessment, video fluoroscopy versus fees, and it's a divided opinion. We have been quite happy with our fees examinations in view of aspiration risks. Again, esophageal phase, there's not much that a fees examination would tell you about. So that again is a video fluoroscopy is a far better tool. There is the cricopharyngeal dysfunction. The cricopharyngeal dysfunction and probably residues and movement of the food bolus past the cricopharynx is probably better visualized on a VFSS rather than on a fees examination. But what the advantages of a fees are is that you can see the laryngeal movements, even the pharyngeal movements better on the fees. So that is where fees probably, as a tool for pharyngeal dysphagia is excellent.
Thank you. Thanks a lot.
Can we move on to the next demonstration? That's a transnasal esophagus. Or are there any more questions? So I think we'll move on to the demonstration of transnasal esophagoscopy. Can we do that?
Sir. Hello, sir. Which video we need to play?
The last one.
One second.
No.
See, Dr. Nilanjan Bhaumik, one is there, no? Yeah. That, yeah, exactly. Yes.
Hello, I'm Dr. Nilanjan Bhaumik. So now we begin the demonstration of the transnasal esophagoscopy. The most common indications for performing a TNE or transnasal esophagoscopy is dysphagia. Dysphagia, that too when the patient pinpoints to it being a low dysphagia or an esophageal dysphagia. Again, laryngopharyngeal reflux, screening for head and neck cancers, then even patients who have globus sensations, they are all indications for performing a transnasal esophagoscopy. So this is the scope that we use to perform a TNE. It has got a working length of 60 centimeters. This is the tip, which measures 5.1 millimeters. This has also got a instrument channel, which is around 2 millimeters in diameter, and we can introduce instruments to it of approximately 1 millimeter size. This has also got a suction port, and this is the insufflation device which is used to insufflate the esophagus. We prefer to do a TNE without sedation, of course, but then we prefer to do it just with local anesthesia to the nose. Very light anesthesia, if at all, to the throat. What happens is if you anesthetize the throat too much, the patient starts having pooling of saliva, which makes the patient extremely uncomfortable throughout the scopy. So we begin the TNE now. Always do a quick check of the TNE prior to starting, both the suction as well as the insufflation. And we begin. This gentleman has already been anesthetized in the nose as well as the throat. Now again, it's very essential that we always go in through the roomier nasal cavity. This is a relatively long scopy. So if the scope keeps hitting against the septum, the patient can get very uncomfortable during the scopy. You see a spur out here. Now it's quite easy to negotiate this spur and go ahead. But then it can be very painful when we are continuously maneuvering the scope inside. So once in the nasopharynx, we ask the patient to breathe in through the nose. Baba, nakane shwas gya. Nakane shwas gya. Khub chan. Khub chan. After reaching the oropharynx, have a look at the lateral pharyngeal walls, the base of tongue, the larynx. See the larynx movements of the E mana, the vocal cord movements, and then finally start towards the cricopharynx. Now, seeing the piriform fossa is relatively easy. Seeing the retrocricoid area, the postcricoid area is quite difficult. Baba, thunki gaya. थूंकी गया. थोड़ा गाल फुगवा. Very good. So when visualizing the postcricoid region becomes a difficulty, there's something called the trumpet maneuver which can be used, and that makes visualization of the hypopharynx relatively easier. Baba गाल फुगवा. आता थूंकी गिरा. हाँ? थोड़ा हळूहळू. And then gently negotiate the scope either through the postcricoid region or through one of the piriform fossae into the esophagus. गिरा थूंकी. You can also ask the patient to flex their head forward so as to make negotiation into the cricopharynx a little easier. Tata. Now, once inside the esophagus, we need to start insufflating. But then, mind you, continuous insufflation should not be done. That fills up gas within the esophagus, and the patient again gets very uncomfortable, keeps burping throughout the procedure. So I'm not insufflating now, and we can see that the esophagus is reasonably open. You need to see the esophageal mucosa, look for any abnormalities. It's always better not to suction within the esophagus because then it collapses the esophagus around your scope. As we approach the lower end of the esophagus, we need to look for the change in the mucosa, the squamo-columnar junction. And here we see the squamo-columnar junction or the Z line. Look for any abnormalities, look for proximalization of the squamo-columnar junction, and then gently through the lower esophageal sphincter, either by asking the patient to swallow or waiting for it to open, we enter into the stomach. Baba. Once inside the stomach, we watch the gastric mucosa, the rugae of the stomach, look for any abnormalities. The scope can be rotated around through its full degrees of rotation. See the greater and lesser curvatures. And then we begin the journey back. Usually the coming out is usually a little more informative than the journey forward. That's because the esophagoscope itself cannulates the esophagus and opens it up to help you see. What we can also watch during our return journey is the secondary peristaltic movements of the esophagus. These are the secondary peristaltic movements that you have seen. It's a slow withdrawal. Again, while negotiating past the retrocricoid region, it's a good idea to see it better. It's one of the hidden areas, and visualizing it can be quite troublesome occasionally. And that's how we come out into the oropharynx again. You can see that the patient has been remarkably cooperative throughout the procedure. He's been comfortable too. In the laryngologist's hands, we do realize that the TNE can be an excellent pan-endoscopic tool, wherein you can do a naso-endoscopy, a laryngoscopy, as well as an esophagoscopy, all during the same sitting.
So as I was saying, the transnasal esophagoscopy has become a pretty strong tool in the hands of ENT surgeons now since the time of its inception. We can do a nasal endoscopy, a laryngoscopy, esophagogastroscopy with the TNE. We can do quite a few procedures again with the TNE. Biopsies. We should be careful that we do not biopsy anything blue within the esophagus. They could be varices, can bleed tremendously. But then biopsies of otherwise, suspicious lesions, surveillance for head and neck cancers. You see the TNE, the patients coming in for TNE, it's a daycare procedure. In fact, it's an OPD procedure. They can just walk in, go out of your OPD all within an hour or so, an hour and a half or so. So it saves a lot of time for the patients, and patients are more compliant doing a TNE. So for head and neck cancer surveillance, TNE is an excellent tool. Barrett's esophagus, then even patients of chronic cough. Chronic cough is something which we keep seeing frequently. Even patients of chronic cough, TNE is an indication for patients who are having chronic cough because of maybe laryngopharyngeal reflux or some other cause. So any questions? Manish, you are using TNE quite a lot. So anything that you would like to add?
Yeah, I mean, find it very useful in evaluating unexplained organic dysphagia in patients, and especially once we got enlightened through works of people like Peter Belvarsky, who enlightened us about the response of the upper cricopharyngeal sphincter in response to lower diseases. So a good assessment of rugae, stomach, and occasionally the lesion there, like a squamous cell carcinoma or Barrett's, really tell us why these people have upper esophageal dysfunction as well, because it's a protective function. So it gives a great reference tool for us to plan comprehensively dysphagia management. Also, along with that, I find it more easy to do things like biopsy and all, and also for triple endoscopy, bronchoscopy in cases with people with voice prosthesis. It's a fantastic tool to see if there's any problem with a voice prosthesis in the neoesophagus, how the valve is sitting. Well, like you said, also in high speed, you could make out some things about esophageal speech. In this case, also, you are able to make out
if there are functionality issues, what is the contraction of the cricopharyngeal fibers, which one has repaired later on after surgery, and why a voice prosthesis is working or not working. Transesophageal transnasal esophagoscopy is a helpful tool when you see the other side of the prosthesis and its function. Very helpful.
In fact, now that you mention voice prosthesis, we have also done a few secondary voice prosthesis insertions on an OPD basis with the help of TNE. So that is something which also can be done. The new Provox prosthesis is it's got everything, you know, with the set itself. So it's an excellent tool to do a puncture as well as inserting the prosthesis. Foreign body removals, well, it is possible, but then the forceps that we have along with the TNE are smaller forceps, so grasping slightly larger foreign bodies may become a little challenging in TNEs. So probably, you know, there are cases wherein you might have to refer them to your GI colleagues. Any other inputs? If Datta sir is there, or Manish, any other inputs?
Yeah, that's just about it for me.
Hello, am I audible?
Yes, sir.
Yeah, so I just had a query that I feel, in my opinion, that all hypopharyngeal cancers eventually should have a TNE in the same sitting when you are evaluating the primary with the flexoscopy in the outpatient department. In addition to this, what previously has been mentioned regarding the prosthesis and the esophageal phalanges, their placement, their fungal load or the burden. Besides that, in my opinion, if you go beyond the cricopharyngeal sphincter, there's very little which is with the ENT surgeons per se.
Sir, can you hear us?
I have you got disconnected?
You're audible, sir.
You're audible, sir. Are there any tips or tricks for beginners if we are planning to start TNE, sir?
Some key points out in TNE are, am I audible? Audible and visible?
Yes, sir, audible and visible.
Right. So some key points out in TNE are that going through the roomier nostril. So what happens is, even if you are able to go in through the less roomy nostril, this is a big scope. Always remember that it keeps touching the septum. Touching the lateral wall of nose does not elicit that sort of pain or that sort of discomfort as touching the septum does. So when you keep manipulating the scope inside, when you are well within the esophagus, the scope, the distal end, or rather the proximal end of the scope, will keep touching the septum, and that is always extremely uncomfortable for the patient. So always going through the roomier nostril. One. Second is negotiating the cricopharynx. Negotiating the cricopharynx can be a bit of a challenge at times. usually ask the patient to swallow once and go in through a pyriform fossa. It's also, there is something called a trumpet maneuver, which I'll need to read up, wherein the patient blows up and blows up everything, and the hypopharynx becomes a little more delineated, and then we can negotiate into the hypopharynx and also visualize the hypopharynx at the same time. As I mentioned earlier, you do not take biopsies of anything blue within the esophagus. You'll have a torrential bleed if it's very, esophageal varices. Within the stomach, well, I don't think there's a lot that we can do within the stomach other than perhaps if there is something small and an obvious thing looking malignancy, maybe take a biopsy. But beyond that, there's not much that we can do within the stomach. That's about it. I always recommend that while coming out, through the esophagus, do not be in a hurry. Come out very slowly, very gently, so that you can visualize the esophagus, the secondary peristaltic movements. A further extended use of TNE could be in assessing esophageal dysphagia, the functional aspects, wherein we can feed the patient some boluses, be it liquid, solids, and see whether there is hold up somewhere, and whether it moves at the way it should. Esophageal transit time is hardly a second or two, but then that if it is prolonged, that probably indicates some sort of esophageal peristaltic issues. So these are some things which a TNE can help you with, and you need to be careful about.
I think I'd like to add up a thing like procedure wise, we have done in post radiotherapy cricopharyngeal stenosis where we found that the person had perceptible dysphagia and less than 1 centimeter of cricopharyngeal bore. So we did the balloon dilatation in the OPD itself, putting a guide wire first through the esophagoscope, leaving the guide wire there, then putting the scope again, and then over the guide wire we could put a balloon and do a dilatation. Very useful thing in the OPD. It's very safe. And also about the esophageal wall, many times you see diagnosed case of this autoimmune disorder with the esophageal dysmotility. Absolutely. And it's very useful in seeing transit time. It's not normal to see food getting impacted for no reason. Even semi-solid food, if it is sticking there, not going down very fast, it's very helpful tool in telling. Then also candidiasis. Frequently you see candidiasis. And can give very nephrology patients having autoimmune and neurological causes. So I find quite a useful tool in going down. You always feel like seeing beyond the cricopharynx and hypopharynx in so many cases as an ENT surgeon, and this instrument has good insight into that. And I'm sure it will have continue. Putting in pH probes, seeing whether the manometry probe is properly placed, all these things because recently all the bariatric colleagues have started referring us to see the anastomosis, but because when I showed them that how easy it is to do reach the stomach in a sitting position in an OPD patient, I don't know how it goes, Niranjan, but I don't think you admit or make files of any patients for TNE, whereas if you have to get an upper GI done in a proper gastro to have an admission for some time.
You are getting disconnected occasionally.
Sedation, midazolam, all those things, bariatric cases for the TNE scope are already. So for bariatric assessment, for anastomosis, all these things we have done with the teams. It's a busy instrument that way.
Absolutely.
Yeah.
So I think that about covers it up for TNE, and I think that about covers it up for this session too. I think we can conclude this session if there are no remaining questions or anything worth discussing any further. Of course, there'll be a swallowing session further on wherein we'll have more questions. So I think we can just conclude this session now.
Thank you. I think we had a great video demonstrations of several procedures and good discussions too. Thank you very much for the opportunity and nice. Thank you.
Thank you. Thank you very much, Dr. Prakash. Thank you.
Thank you, Dr. Nilanjan. Great as always.
Thank you very much, Manish. Thank you very much. It was very, very, very valuable inputs from both you and Dr. Prakash. It was a very enriching session for me too.
Am I heard? So, Dinesh, can you hear me?
Rakesh sir, we can hear you. Continue, sir.
Okay. So after we finish this very educative and basic instructional course on all types of techniques which can be used for evaluating swallowing as well as voice, we move on to the next session, and it gives me an opportunity to introduce two very young and energetic people who are working with me, and both of them are interns. Okay, so they are interns who are working with us on a posting, and they have been a sort of backbone behind the nerve center which we have set up in Lucknow. So I have requested them to chair a session. So I felt that the interns should be also given a place. Otherwise, they always remain the backless faces. They sort of are never seen and never heard. So two interns who are there, Venkat and Shirvan, will be chairing this session and introducing us. So, and it's their first attempt in their lives doing this, and they're already very impressed with the quality of the talks. So I hope all of you will support them and give them a big hand once they do it. So I'll hand you over to the chairpersons of this session, Sherwin and Venkat.
Good afternoon to everyone present here. It is really our pleasure to be able to chair this session. Our first speaker today is Dr. Arun. He will be presenting to us a talk on the role of dilatation in TCS. So, Sir is a senior consultant and assistant professor at the Department of ENT and Head and Neck Surgery at Bir Hospital in Nepal. He has done his post-graduation from the Institute of Medicine in Tribhuvan University. He has completed 1 year senior clinical fellowship in laryngology from DMH, England in 2019. He is a member of the Society of Otolaryngology of Nepal, and he is the editor of the Nepalese Journal of ENT and Head and Neck Surgery. Over to you, sir.
Thank you very much. Thank you very much. First of all, I would like to thank the organizing committee Dr. Rakesh Srivastav, Dr. Rakesh Datta, and Dr. Sachin Gandhi for giving me this opportunity to speak something on the role of dietitians in case of laryngotracheal stenosis. I just want to share my screen. Am I audible, sir?
Yes, sir.
Okay. Okay. The role of dietitian in LTS. Laryngotracheal stenosis basically is a narrowing of airway due to the scarring. It can be divided into laryngeal stenosis, which can be further divided into supraglottic, glottic, and subglottic stenosis, and tracheal stenosis. And the glottic stenosis, especially the posterior glottic stenosis, is very difficult to treat and with poor outcome compared to the tracheal or subglottic stenosis. There are various causes of laryngotracheal stenosis. I don't want to go in details, but broadly, it's congenital or acquired. In acquired, it's basically the traumatic. We get a lot of traumatic patients in our hospital, especially the blunt trauma to the neck following road traffic accidents, the strangulations, and sometimes even the suicidal and the homicidal cut injuries. And this year we got some patients of post-COVID, post-intubation patients, and sometimes we may also get patients with neoplastic or inflammatory cause. And we also got one case of idiopathic subglottic stenosis, which we couldn't find any cause. And if we don't find any cause, we label it as a idiopathic subglottic stenosis. This also, I think, has been covered in detail. I just want to highlight the procedure which we do in our hospital. The flexible endoscopy, it has become the cornerstone of assessing any airway cases. We identify the site of the stenosis and especially the mucosa overlying the airway. It's very, very important. A pulmonary function test is basically it's a functional, then anatomical, and it helps in comparing the outcome of our procedures. Imaging, though it's not that much used in airway, but sometimes when you suspect the neoplasm or when you suspect the external cause, extraluminal cause, we go for the imagings. And in all the airway cases, we routinely do fees. The aim of our evaluation is to identify the exact site of the stenosis and the length of the stenosis. And if the patient is trachostomized, we need to identify the length of the stenosis from the stoma and similar the stomal size and from the stoma to the carina. And we follow the Mere-Cotton classifications for all the laryngotracheal stenosis. And this is the spirometry showing the flow volume loop. In case of fixed airway obstructions, we get this kind of the loop. Going briefly to the history, this dietitian started in 1871 by Law L. von Sutter from Vienna. He dilated the airway using hard rubber bushings through the mouth. Similar procedure was done in US in 1885 by O. Dyer. In 1982, the Simpson, he used the CO2 laser to excise and vaporize the scar tissue. And in 1987, Sapse, he designed the classical incision for which his name is there, the radial incisions. And in Stanley, he used different kind of laser with good results. Basically, any airway procedure is a teamwork. There should be a very good coordination between the anesthesiologist, the surgeon, the theater staffs, and the critical care units. And we need to sit together. We have to plan and plan and plan. We need to make plan E. If it doesn't work, it's plan B. If it doesn't work, plan. So we need to plan a lot for any airway procedures. Going to briefly the indications for endoscopic dilatations. Usually we do it for grade 1, grade 2, or sometimes in mild grade 3 stenosis. Grade stenosis length less than 1.5 centimeter, and usually thin cicatrical wave, they do better with the dilatations. And there are various contraindications. The external compressions, tracheomalacia, and loss of cartilage support, which we can see in this figure, is an absolute contraindication of the dilatations. And when the length is more than 2 centimeter or a grade 4 stenosis without any detectable lumen, a congenital subglottic stenosis. Basically, if it's a cartilaginous, so we do not do dilatation in case of congenital subglottic stenosis. And these are the relative in contraindications. And one thing is we cannot keep on dilating the patients for several times. Some people, they keep on dilating, but I think we should stop when the recurrence is there to initial grade for dilatations. We strictly follow this because after doing 1 or 2 dilatations, if the patient comes with the same grade of stenosis, we should stop doing it. And this is our OT setup. This is how we position the patient. This is the tubing for high nasal flow, HFNC, high flow nasal cannula. We have high HFNC in our theater. It can help us to anesthetize with apnea technique. It provides 100% oxygen at the rate of 70 liters per minute. And for 30-40 minutes, we shouldn't have any problem even if you don't intubate the patient. And after intubating, after the suspension of larynx, we just evaluate the patient. And we have the AccuPulse Duo. We use both the micromembran as well as sometimes in tracheostomies, we use the fiber as well. And after doing the endoscopy, we just made a radial incisions 12 o'clock, 3 o'clock, 9 o'clock, and 6 o'clock. But we have to be very careful while giving the posterior incision because it's very close to the esophagus. And after making the incisions, we can dilate the airway either using the angioplastic balloons or the rigid bronchoscope, or like what we do in our industry is the Saburi dilator. We have different numbers of Saburi dilator, and we use that. And after dilatation, some prefer to use mitomycin C with concentration of 2 milligram per ml for 1 to 2 minutes, but we don't do it in our institution. We inject triamcinolone at the site of the dilatations. But like airway, there is no fixed things which we always follow. For instance, in this case, the patient had the supraglottic stenosis. The patient is non-tracheostomized. I don't know how the patient is eating and breathing through this hole. Actually, we plan to tracheostomize the patient, but with the coordination with anesthesiologist, what we did was we first dilated this and then intubated the patient with a smaller tube, and then made a radial incisions with a laser followed by the dilatations. And after 2 dilatations, this patient did well. And the patient, luckily, the patient is not tracheostomized, and patient is doing well. Now, coming to the predictive factors of success or failure in endoscopic management of laryngeal and tracheal stenosis, it was published by Simpson in 1982. It was studied in Boston Affiliated University Hospital, and they found several factors. For example, the circumferential scarring wider than 1 centimeter in vertical dimension, tracheomalacia, previous history of severe bacterial infections associated with tracheostomy, posterior laryngeal inlet scarring with arytenoid infection. These are the 4 prognostic factors they identified. This paper is an excellent paper written by Philip Monier and was published in UAM Archive in 2005, which they have done the study on the role of CO2 laser in the management of laryngeal stenosis. 100 patients were enrolled in the study, and out of which 12 patients with grade 1 and 41 patients of grade 2 and 47 patients of grade 3. And if you see the success rate, in grade 1 it's 92%, grade 2 it's 46%, and grade 3 is 13%. Here we can see the drop in the success rate with the severity increase, with the increase in severity. In the same article, they have tried to formulate an algorithm for going either endoscopic surgery or open surgery. For endoscopic surgery, they have formulated as like the grade 1 subglottic stenosis, grade 2 or mild grade 3 subglottic stenosis can be done with endoscopic surgery. Similarly, stenosis length less than 1.5 centimeter, membranous glottic wave, interarytenoid adhesions, and postglottic stenosis without cricoarytenoid joint fixations. And similarly, they have also formulated the indications for the open surgery. For instance, grade 2, grade 3, grade 4 subglottic stenosis, cartilaginous stenosis, loss of cartilage support if the length of stenosis is more than 1.5 centimeter, and post-glottic stenosis with cricoid joint fixations. And even dilatation was studied in the pediatric patient as well. It was done by Montella recently, and it was published. There were 74 patients with grade 1 to 3 subglottic stenosis with average follow-up of 43.5 months, and 82% responded to the treatment. And they have found that the previous time of intubation and the presence of tracheostomy were the poor prognostic factors for the dilatations. This study was done by Soil Kilo. They have done compared the long-term results of endoscopic dilatations. 54 patients with average follow-up of 1 year. They found the cure rate of 40.7% and improvement rate of 46.3%. And in their study, they have found that the length of the stenosis and the type of operations were the factors were the predictive factors which were statistically significant. More the severe the stenosis, the less poorer the outcome. Similarly, the type of operations, whether it was done for a curative purpose or was also purpose, for example, after every open air surgery, sometimes we need to dilate the patient. The patient with touch-up procedure, they responded well compared to the curative patients. This study was done when I was doing fellowship in Pune. The transvalular laser surgery followed by endoscopic dilatation for grade 1 and grade 2 tracheal stenosis. It was a prospective study done by one of our residents, Dr. Parizat, and 25 patients were enrolled in the study for duration of 1 year. And the pre and post intervention parameters used to evaluate were grading of stenosis.
most involved here, and join us and once they're verified as those whether they are speech technologists or anesthetist or anyone dealing with the business of the professionals working in laryngology and upper air.